Good afternoon. My name is Brendan. I'm a physical therapy student from Howard University, and today we are going to be discussing an MSK pathology known as lateral epicondylitis. So, first we're going to go over the gross anatomy, and this just shows the three bones that comprise the elbow complex. So, at the top, we have the humerus, and then we have the specific um, parts of the humerus, so the coronoid fossa, you've got the medial and lateral condyles, you've got the trochlear, capitulum, so on and so forth. And then you've got an anterior and posterior view of the humerus. And then same thing, you have the ulna right below the humerus, and then the radius, and then you have the different parts. And a lot of the muscles and tendons insert to these specific parts of the bone. So I'm not going to go into too much detail with the anatomy. All right, so this just shows the gross muscle anatomy of the elbow complex. So as you can see, we have both muscles that insert on the anterior surface of the forearm. So that would be all through here. And then we also have muscles that insert on the posterior aspect of the forearm. And then they have superficial and deep compartments. So the superficial layer is going to be the muscles that sit more superficially, and then the deep layer is the layer of muscles that that are sitting under the superficial layer. So you've got flexor carpi ulnaris, pronator teres, so on and so forth. And then, as you can see, the almost all of these muscles are originating on either the lateral epicondyle, where all the extensor muscles are going to be, or the medial epicondyle, where all the flexor muscles are going to be. So muscles that are responsible for curling the elbow, flexor, or extending the elbow, extensors, um, or extending the wrist and extending and flexing the wrist, I should say. Then All right, so now we're just going to go ahead and define what lateral epicondylitis is. So lateral epicondylitis is a pathology that occurs when the tendons that attach to the lateral epicondyle become inflamed due to overuse, leading to pain and irritation of the wrist extensors. And then the mechanism of injury is excessive loading of the wrist extensor muscles. And then the specific motion that loads the wrist extensors or pulls the wrist extensors in their most taut position are going to be elbow extension. So elbow extension, forearm pronation, pronation, and then wrist flexion. So as you can see, there are a lot of activities that we go through throughout the day that require this motion of the elbow extension, wrist pronation, forearm pronation, and wrist flexion. One, I guess, really good example of this would be swinging a tennis racket. And that's the main reason why it's commonly referred to as tennis elbow, because when you're swinging a tennis racket, you're in a pronated, extended, and then wrist flex position. And then that repetitive load um, is going to eventually cause inflammation within that insertion point of the lateral epicondyle. So all those muscles that are inserting right there get irritated over time. And then this just is the prevalence of the disease or the pathology. So lateral epicondylitis most commonly affects people between the ages of 40 to 60 years old, and it usually affects women more than men. And then there's a higher risk in people who partake in repetitive forceful manual labor, especially tasks involving wrist extension or gripping. So basically, people who are um, participating in manual labor tasks have a higher chance of getting this pathology. And of course, athletes as well. Okay, so this is just going to be the clinical presentation of the pathology. So the patient reports insidious onset of pain and tenderness at the lateral epicondyle that worsens with activities requiring forearm pronation and wrist flexion. Tasks such as using tools, gripping, or lifting objects with the wrist in a flexed or pronated position can intensify symptoms and trigger flare-ups. So this is what I was saying earlier. A lot of manual labor tasks, Basically, any motion where you're constantly using your arms and wrists can can increase, I guess, the chances of somebody getting this pathology. Okay, and then so next we're going to go into differential diagnosis for lateral elbow pain, and lateral elbow pain is a very broad description. Like it could mean a lot of different things. But this is the common pathologies that are usually causing the lateral elbow pain. We've got nerve entrapment. So the radial nerve is the nerve that runs all the way down the posterior compartment of the wrist and forearm. And it commonly gets entrapped, believe, like right in this vicinity right here. So when it gets trapped, then that's going to compress the nerve, and that can cause a lot of radiculopathy-like symptoms. So it can cause some burning, it can cause some tingling, it can cause a deep achy pain. But it's important to remember that it's usually not going to cause any muscular weakness because it's going to be a peripheral nerve issue, not a central nervous system issue. So the muscles are going to be fine, but it's just going to be the sensation that's impacted. And then we also have an LCL injury. So the LCL is one of the ligaments that are surrounding the elbow complex. And if those ligaments are strained due to like excessive varus stress, that can cause significant problems because that ligament is ultimately going to create pain if it's strained. And then we've got cervical radiculopathy, and this is actually the compression of the nerve root. So we know that we have the different cervical vertebrae, and then we have nerves that are branching off those vertebrae. And when those vertebrae are damaged, they can compress against the nerve root, and that can cause pain to be referred all the way from the shoulder. It's going to radiate down from the shoulder, down the extremity, and then it can also cause elbow pain, depending on which uh, cervical nerve or nerve root is impinged. Then we've got osteochondritis dissecans, and that basically is going to be the bone damage to the capitulum, and the capitulum is it's going to be one of those bony landmarks of the elbow complex. If you look at the previous slide, you can see it, and it's common in young athletes, and it can present with a locking or catching or a stiff sensation as well. Okay. Next slide. Okay, so I just decided to throw this slide in there, but this basically just shows the different special tests that you can use to either rule in or rule out lateral elbow epicondylitis. So we've got the Cosen's test, and basically with that test, you would be palpating the lateral epicondyle, and then you would ask the patient to perform elbow extension, uh, forearm pronation, and then wrist extension, and then you would be resisting and trying to move them into wrist flexion, and then you would see if that produced any pain. And after that, you've got the Maudsley's test. Basically, you're just going to be asking the patient to extend their hand all the way, and then you're going to be applying resistance against their leave ring finger, and then you're going to see if there's a production of pain. And then the last one is Cozen, Maudsley's, Mills. The last one is Mills. So basically, the patient's going to move into elbow flexion, and then you're going to have them perform wrist pronation, and then you're going to have them perform wrist flexion, and then you're going to passively move them into elbow extension. And then the thing about all three of these tests is that they stress the tendinous insertion point where all the posterior muscles of the elbow complex insert, so that lateral epicondyle. So if those muscles are irritated, if the muscles tendinous insertion is irritated, there's going to be a significant production of pain. Okay, so on this slide, we basically just have, this is an outcome measure for lateral epicondylitis, and it's the pain-rated tennis elbow evaluation form. And we've got three different categories in the domain section. So we've got pain, functional specific activities, and then we've got functional activities. So basically, this is going to be like your ADLs, your BADLs, the different categories. I'm not going to go into too much depth, but patient can rate their pain response, and that kind of gives them a rough estimate of, I guess, the severity of the condition. So then next we are Okay, so next we're going to go ahead and discuss some interventions. So we've got the 6 primary intervention categories. We've got exercise, we got manual therapy, we've got bracing and counterforce strap, we got modalities, we got injection therapy, which is corticosteroids, and then we've got education and activity modifications. So the most common exercise that clinicians usually prescribe is going to be eccentric loading of the extensor carpi radialis brevis muscle. So basically, that's going to be loading the muscle, or basically you're extending the muscle while controlling the descending phase with that load. So if I could demonstrate, you're going to move, you're going to first move into pronation, extension, and then wrist flexion, and then you're going to have some sort of resistance, and then you're going to be moving down eccentrically. So you're controlling the amount of force. You're controlling the load. As the load is trying to pull you in the opposite direction, you're moving down into an extended position. And over time, that's going to strengthen those muscles and increase their durability. And then for manual therapy, we just got some mobilization with movement, some soft tissue massage, and then some joint mobs of the elbow and forearm to reduce pain. These are commonly combined with exercise. And then we've also got modalities, so we've got some shockwave therapy and a little bit of ultrasound for the same thing to reduce some of the pain, and then induce cellular perforation. And next, we've got injection therapy, so that's going to be your corticosteroids. These are usually prescribed as a short-term treatment option, but we don't want to be using corticosteroids long-term. And then for our exercise and activity modifications, we want to modify and reduce aggravating activities, and then we want to optimize ergonomics and gradually return to function. So any activities that are causing or irritating at lateral epicondyle and those muscles that insert the lateral epicondyle, we want to try to reduce as much as possible. Okay, so next we're going to go ahead and discuss our prognosis. So according to a 2025 BCM musculoskeletal disorder article, lateral epicondyle patients improve within 6 to 12 months under conservative management. About 10 to 12% of patients develop refractory symptoms lasting beyond 6 months. The study found that patients who had weaker grip strength on the affected arm compared to their other arm were more likely to still have symptoms after 6 months. Lower initial grip strength predicts a slower or less complete recovery from lateral epicondylitis. So basically just saying that patients who already have weak grip are predisposed to getting it and then having a slow recovery. And then the reflection to PT practice from reviewing the most up-to-date evidence-based research and clinical protocols For lateral epicondylitis, I gained valuable insight into how this condition is treated and monitored. I also learned how to carefully differentiate lateral epicondylitis from other conditions that can produce similar symptoms, such as cervical radiculopathy. By systemically evaluating pain, location, provocative movements, and neurological findings, working through this case helped me see how to apply my differential diagnosis skills in practice, ensuring that I can identify the key features that distinguish lateral epicondylitis from other pathologies, make informed decisions for assessment and treatment. Okay, and then after that, we've just got my reference page, and that is all. So thank you for watching my presentation, and I hope it was educational.